this is the first of two podcasts on liver pathology. In this first podcast, I'm going to outline some important principles of liver disease. For example, I'm going to look at some of the basic anatomy and physiology of the liver. I'm then going to look at acute and chronic liver disease, and then finally look at some of the terminal pathways in liver disease, such as hepatic failure and cirrhosis. So the liver is the largest solid organ in the body, having a weight of 1,500 grams. It has a dual blood supply via both the portal vein and the hepatic artery. Important cells of the liver include hepatocytes, bile duct cells, blood vessel cells, Kupffer cells, and stellate cells. A brief word on stellate cells because they're particularly important in the pathophysiology of cirrhosis. These cells are found between hepatocytes and endothelial cells, and their normal function is the storage of vitamin A. However, following injury, there is activation of these cells with laying down of collagen. However, I'm going to go into this in slightly more detail later. It can be useful to regard the liver as a large sponge in which the holes represent vascular sinusoids that are filled with blood flowing from portal tracts on the outside to central veins at the centre. These portal tracts are composed of hepatic artery, bile duct, and portal vein, and are surrounded by a structure called the limiting plate. Blood therefore flows from portal tracts, along the sinusoids, and into the central vein. The liver has a wide variety of functions, including metabolic, synthetic, storage, and detoxification functions. When pathology affects the liver, some or all of these functions are disturbed, and this fact can form a useful basis for investigations into liver disease. For more on the investigations in liver disease, listen to the Chemical Pathology podcast on liver function tests. So there are 5 important pathologies that affect the liver. These are infections, alcohol, drugs, metabolic conditions, and autoimmune disease. In the second part of this podcast, I'm going to look at these specific pathologies. But now I'm going to specifically consider some of the disease states that often result from these. Firstly, I'm going to talk about hepatic failure. So hepatic failure is a clinical syndrome where there is a 90% reduction or greater than 90% reduction in the functional capacity of the liver. There are 2 types of hepatic failure: acute hepatic failure and decompensated hepatic failure. In acute hepatic failure, a sudden, massive injury to a normal liver causes the failure. But in decompensated hepatic failure, a relatively minor insult, often to a cirrhotic liver, causes failure. There is no such thing, therefore, as chronic hepatic failure. There are 3 important features of hepatic failure. These are hepatic encephalopathy, which describes a spectrum of neurological and behavioural symptoms resulting from accumulation of toxins in the brain; severe coagulopathy, due to a reduction in clotting factors, most often manifested as a bleeding disorder with an increased INR; and jaundice, predominantly of conjugated bilirubin. If the hepatic failure is decompensated, there may also be signs of chronic liver disease, such as palmar erythema, spider nevi, splenomegaly, and ascites. Hepatic failure is a serious problem and is associated with lung and kidney failure in the hepatopulmonary syndrome and hepatorenal syndrome, and an increased incidence of infections. Patients often die from this condition. As I've already alluded to, there are a number of states that precede hepatic failure, and I'm now going to talk about 3 of them. These are acute liver disease, chronic liver disease, and cirrhosis. So the 6-month line is really the cut-off between acute liver disease and chronic liver disease. So in acute, the liver damage has completely resolved within 6 months, while in chronic it persists greater than 6 months. The most common causes of acute liver disease are acute infection with, say, hepatitis virus, alcohol after a heavy binge, or with various drugs. Signs and symptoms are exceedingly variable. People may be totally asymptomatic. They may have very mild symptoms such as transient fatigue, nausea, or they may have full-blown acute icteric hepatitis, which characteristically has 2 phases: a prodrome with systemic upset, mild fever and upper abdominal discomfort, and in the second phase jaundice, plus or minus pruritus depending on the level of cholestasis. Full-blown hepatic failure is quite rare, but may occur, for example, with, say, paracetamol overdose. Chronic liver disease, as we've already said, is liver damage that persists greater than 6 months, and this has many, many causes, which I'm going to really consider in the second podcasts. Signs and symptoms are of 3 types. Patients may be totally asymptomatic, with their liver disease being discovered purely by chance on an LFT panel, and this contributes to the majority, up to 80%, of patients diagnosed with chronic liver disease. They may also have symptoms of chronic liver disease or cirrhosis. This accounts for 15%, and often these symptoms are quite mild, or they may have an unresolved episode of acute icteric hepatitis. This contributes around 5% of patients. It's exceedingly important to try and find the cause of chronic liver disease, as some pathologies can be stopped early in the disease process and prevent serious sequelae. So it's very important, therefore, to do bloods, imaging, for example, ultrasound, and possibly even a liver biopsy to confirm the reason for this problem. So lastly, in this introductory podcast, I'm going to talk a little bit about cirrhosis. The first thing to say about cirrhosis is that only a minority of people with chronic liver disease go on to develop cirrhosis, and it's not known why this is. It's thought there are possible susceptibilities in certain individuals that can predispose to this process. Basically, cirrhosis is a state of whole liver fibrosis with nodules of regenerating hepatocytes that results in distortion of liver vascular architecture. Pathophysiologically, the key cell, as I said earlier, is the hepatic stellate cell that sits underneath endothelial cells of the liver sinusoids. If any injury occurs to the liver, there are cytokines released specifically from Kupffer cells that cause activation of the stellate cells and secretion of collagen and fibrosis. Cirrhosis can be classified in 2 ways. The old system is via the nodule size, with micronodular cirrhosis being less than 3 centimeters, macronodular greater than 3 centimeters, or now via etiology, so say alcohol cirrhosis or hepatitis cirrhosis. Complications of cirrhosis can be divided up into 2 types. These are portal hypertension and hepatocellular carcinoma. Portal hypertension occurs because of disruption of the liver architecture and therefore increased resistance to blood flowing through the liver. The most important sequelae of portal hypertension are splenomegaly and portosystemic anastomoses, which include esophageal varices, which may burst and cause massive hematemesis, and caput medusa, often seen around the umbilicus. Hepatocellular carcinoma results from the increased cycles of hepatic cell loss and regeneration. The signs and symptoms of cirrhosis are interesting because most patients are asymptomatic. There are, however, usually a number of stigmata that give away the presence of this condition. These include caput medusae, splenomegaly, easy bruising, and a liver flap. The development of ascites and jaundice are ominous signs which suggest possible decompensation and liver failure. As discussed earlier, the natural history of cirrhosis is an inexorable progression to hepatic failure and death, usually because a precipitant such as an alcohol binge, intercurrent infection, variceal bleed leads to decompensation, hepatic failure, and death.